Now Media. I'm Jim Jack with Now Media. A little bit of a false start there. With me, Dom Lucyk, Communications Director with 2nd Street. And you sent out a press release the other day that caught our attention, and it shows that 1,600 patients died waiting for healthcare in British Columbia's Interior Health Region. That's our region right here. And it marks like 6-year high for waitlist deaths in the region.
Yeah, that's right. The Canadian healthcare system is failing, and it's not just unique to BC, but absolutely here in Interior BC. The problem has been bad for a long time, and it's only been getting worse.
So well, we're getting some feedback there. This number is quite shocking, but when it says 1,600 patients died waiting for healthcare, not necessarily died because of the surgery they're waiting for, just that because some of these are like CT scans, and some of them are like cataract surgery, knee surgeries, and that. Of that 1,600, who actually died because they didn't get the surgeries they required?
Yeah, the unfortunate thing, Jim, is that we don't know for sure with this case. Basically, the way that Interior Health broke it out is they gave us three surgical procedures that people died waiting for: cataracts, knee replacements, and stent insertion and removal. And they broke the numbers down for those, but then the rest, the remaining 106 surgical waitlist deaths, they just filed that under other surgical procedures. So we actually don't know for sure how many people died because they were waiting for something like a heart surgery or a brain surgery or cancer treatment or something like that. And then also just the vast majority of these cases are people waiting for diagnostics. So in that case, they didn't even know what was wrong with them when they died on the wait list.
Yeah, we got this one table that we're going to put up here. Maybe you can talk us through this table here, if you could put that up. Yeah, so that's part of the 1,600 there, and then we're going to look at the other table there. So that's bookings canceled because the patient died while waiting for these scans and that.
Yeah, that's right. And the reason that we have to, the reason that it's phrased that way is because oftentimes governments, including in Interior Health, don't actually, proactively track the number of patients who died waiting for healthcare. So this phrasing of, give us the number of bookings canceled due to patient death is kind of a workaround that we thought up to get this data from governments. But yeah, again, it's not usually actively tracked. And so, yeah, as you can see here, 584 patients died waiting for CT scans, 302 for ultrasound, 151 for MRI. Now, sometimes patients can go in and get a diagnostic and find out that nothing is wrong with them, but sometimes they can go and find out that something is very seriously wrong with them. And so when you're on a wait list for a diagnostic, and you hear stories of people waiting months, maybe even years for diagnostics like this, it's just indicative of how much of a backlog we have and how much the system is failing people.
Yeah, well, we did a story just recently, I think a few months ago, about a young lady that had a brain tumor, and they told her that it was about an 8-month wait for her to get a scan. And I was speaking with a doctor. I went to a longevity conference in San Francisco, and I was speaking to a doctor down there. And I told him that story, and he said she needs to leave immediately, and she needs to come down here. And he said that he could likely get her in for a scan for $200 somewhere. And I was just like, what?
Yeah, and you see this happening more and more. I'm not familiar with that particular story of this one brain tumor. I really hope that that has worked out well and she's gotten the care that she needed. But yeah, you do see this often. There was a really famous story on Vancouver Island of a woman named Alison Ducluseau who had an aggressive form of cancer. And she was told by the system in BC that she just wouldn't be given care. And so rather than resigning herself to death, she went down to a clinic in the US and received a life-saving surgery, and she's doing fine now.
So this is it's a benchmark. So this is how you're having to track these stats. So this is a benchmark as well. And this is a 6-year high. So this thing is showing progressively the situation getting worse, no matter how you kind of look at these numbers. It's the same benchmark you've been using over 6 years.
Yeah, yeah, absolutely. So yeah, if you look at our numbers, because we've been doing this since 2019, and we'll usually do it in a big annual report and just include all of the data from across the country. But we got Interior Health's a bit early this year, so we thought we'd just put it out right away. Yeah, so in 2019, there were 767 waitlist deaths in Interior Health, and now that's just about doubled, or right around doubled, to nearly 1,600. So, yeah, the problem was already bad, and it's been getting worse. And I think it's time that we start talking about some actual, real health reform in BC and across the country.
So what is are you tracking the wait times as well? Like say for CT scans and MRIs, are you tracking that as well? Like how long those have been, like, are those getting worse, obviously?
Yeah, I don't have the numbers off the top of my head right now, but the Fraser Institute tracks surgical wait times, and I believe diagnostic as well, and those have been trending up.
Yeah. So, and maybe tell us a little bit about your organization first of all here, Second Street Org. What is it that you guys do, and I guess why?
Yeah, yeah, for sure. So we noticed that the healthcare system has been failing people, and we decided to look into the problems and look into how to fix it. So it's kind of like a two-part process of what we'll do. We'll look into the issues with things like looking up the number of people who have died on wait lists. We have some research on the total number of Canadians on wait list. We've done some research on doctors and nurses leaving Canada to go work in the United States. So we'll dig up that research, and then we'll also look into the solutions. So we've done a lot of profiles of healthcare systems around the world that are universal and perform better than Canada. We've been to Sweden, we've been to France, I've been to Lithuania and Ireland, and so we'll kind of look at those better systems. Say, why does Canada have to lag behind? Why can't we do what they're doing?
And what have you found? Why is Canada lagging behind?
Yeah, so there are a number of like broad systemic reasons. One of them is the way that we fund hospitals and clinics. So in Sweden, in Denmark, in Australia, they have a thing called activity-based funding, which the way it works is instead of just giving hospitals a big check and saying, "Hey, do your best," which is how it works throughout most of Canada, they will actually fund hospitals in part based on the number of procedures that they provide. And so what this does is it kind of changes the relationship between the hospital and the patient. Instead of the patient being seen as kind of an obligation, like, oh, we have to take care of them, it's oh, we get to take care of them because there's a financial incentive for us. So that's been shown to make costs less on a per procedure basis, and also just raise the number of procedures done throughout Europe. It's actually starting to come into play in Canada a little bit. Quebec has been using it for some diagnostic procedures, and they've been seeing success. And Alberta actually just recently announced that they'd be moving over to that funding model. So that's one of the things they do differently. Another is that they will allow patients choice broadly. Here in Canada, it's very rare. There are lots of red tape and regulations that stop patients from being able to pay for care if they choose to, especially when it comes to surgical procedures. There are private clinics in Kelowna, even in Vancouver, but they have a lot of trouble being allowed to provide care to patients from BC. That's not so in places like Sweden and France. And the good thing about allowing patient choice is that it just kind of brings more resources into the system overall, and it just helps take pressure off of the public system. So those are two of the really big ones, and there are a number of other changes as well that we could copy from Europe, Australia, and just better healthcare systems.
Isn't that similar to the U.S. system too? Because it's like the hospitals are kind of like private businesses as well. They kind of run it on a revenue basis.
The difference, though, being is that they don't have a universal healthcare system in the United
Okay.
States.
Right.
In Europe and Australia, they, as we do, have a taxpayer-funded universal healthcare system. You don't have to pay out of pocket if you don't want to. The difference is allowing that choice.
Yeah, I mean, it's in your press release here, there's a couple of things that are really quite shocking in here. This is the small 3-year-old boy that was on a wait list for so long they were giving him fentanyl for pain management during that long wait for surgery.
Yeah, that's right, and that was just related to the pediatric unit shutdown at the Kelowna Hospital. That I'm sure you've been talking about with your audience, because it's just been shocking. And I think that as more and more of these really shocking things happen and people are suffering because of them, I think people are starting to realize that the system just isn't working and we need to make some really fundamental changes.
When you guys are looking at stats, did you have any insight as to why this so many pediatricians quit the hospital but are still in the Kelowna area, and perhaps how they can get them back to work there?
Yeah, I mean, I think one of the ways, generally speaking, that you can incentivize doctors and nurses to stay within your city where you want them is to again allow more choice. If you have things, excuse me. If you have more private options, oftentimes doctors and nurses will find those positions more desirable. We actually did a project a couple of years ago where we surveyed nurses who lived in Windsor, Ontario, and who worked in Michigan. That's obviously a very unique case because of the fact that it's 5 minutes across the border there. But a lot of those nurses told us that they preferred to work in the United States, not just because of the fact that they can get more money at a private clinic or hospital, but because they just enjoyed the work atmosphere more. It was easy. The scheduling was easier. They were able to achieve a better kind of work-life balance. And so if you allow more private care within the country, that is a way to incentivize doctors and nurses to stick around.
And that is one of the reasons that's been cited for the problem in the KGH here, and it said it was a toxic work culture, and that's why a lot of the doctors and that have left, and that led to the resignation of the CEO, Susan Brown.
Yeah, absolutely. I mean, and it's you hear this everywhere, right? If you have a friend or a family member who's a doctor or a nurse, you've probably heard all sorts of horror stories about how difficult it is to work in healthcare in Canada. And I mean, it's not shocking, right? It's high pressure. People are losing their lives, and it's not the fault of any individual staff member. Generally speaking, doctors and nurses are great at their jobs, and they care a lot. But just with how the system is set up, things are just not being done efficiently. And that's a hard work environment to work in. Whether you work in news like you do, Jim, or you work in the think tank space, or whatever job you have, if you work in a high stress environment where things aren't getting done the way they should be, you're not going to be happy.
Just a question for you on your funding model. How is it that you guys are doing all this research and you're traveling the world and checking out healthcare systems? What is your funding model?
Oh, secondstreet.org.
Yeah.
Yeah, it's donations based.
Oh, okay, great. Anything else you want to add for today?
Jim, I think it is just that it's time for health reform. Everything that we're talking about here just feeds into the fact that putting more and more money into the system isn't going to help. We've been doing it for the past 30 years. Spending has been going up on healthcare across the country, and results have only been getting worse. So I think really the big takeaway is we need to look at places that have figured it out and do what they're doing.
Yeah, one of the bigger problems here, it'd be great if you guys would look at it, is the amount of ER closures in the smaller rural hospitals here in British Columbia. That thing seems to be getting out of hand. We're doing like a story, like at least once a week of an ER department closing, and then people are asked to drive, a couple 100 kilometers sometimes over snow-covered mountain passes to get ER care.
Yeah, absolutely. You're right. That we can definitely put that on the to-do list.
All right, thank you for your time this morning, Dom, and I guess keep working away at it. The only way we can get change is by shining a light on where the problems are, and then you're obviously offering solutions as well by looking at regions that are working, so that's great.
Yeah, and that's why I appreciate very much you having me on, Jim.
And we'll have you on again, I'm sure. Again, thank you, Dom, and we do thank you for watching Now Media.
We don't just report the news. We live here too. We're your neighbors, bringing you stories that matter to all of us. No government funding,